Welcome back. We're going to continue our discussion on respiratory diseases with evaluating diseases and disease states of the upper airway. These next few lectures, we're going to go over a brief overview of the presentation of each of the common respiratory diseases. But please understand that this is not a full and comprehensive review of each of these pathophysiologies. You should use your supplemental learning materials, textbooks, other lectures, and reading material to further dive into each of these and really hone in onto the presentation, the assessment variances, and the treatment modalities for your various certification levels for each of these. The predominant disease that we look at in the upper airway is honestly obstruction of the upper airway. This can either be by a foreign body airway obstruction or the tongue obstructing the airway. And we talked about this a lot in some of the airway chapters, but it's worth hitting on again that the tongue is the primary occlusion of the upper airway and can be easily manipulated to allow adequate ventilation and ultimately restore respiratory rate and effort for most patients, either using a head tilt chin lift, a jaw thrust maneuver, or simple airway adjuncts such as OPAs and NPAs. Patients with dyspnea may have an airway obstruction. It could be, like I mentioned earlier, it could be a foreign body airway obstruction. It could be the tongue, or it may be secretions or emesis or blood caused by underlying injuries. Make sure we assess the airway because when we talk about respiratory emergencies, the airway is the path in which air gets in and out. So it becomes crucial to make sure that we're assessing that and managing that to allow the respiratory system to function appropriately. Another disease of the upper airway that we look at is aspiration. Aspiration has a high mortality rate, not just in the sense that it's acute and needs management promptly if occurring in the pre-hospital setting or encountered by the EMS professional, but the aspiration of foreign materials can later lead to subsequent infections like pneumonia, which carry a relatively high mortality rate for hospitalized patients. Make sure that we assess to determine any scenarios of sudden onset dyspnea or shortness of breath, specifically after or immediately after eating, or if the patient has a gastric feeding tube, can also be aspirated, or materials can be aspirated and cause additional problems there. Croup is inflammation and swelling of the pharynx, larynx, and trachea. It is hallmarked with a presentation of the seal bark cough. And I'm sure you'll find some additional videos in the learning material and audio files that help you listen to this. And it's a very distinct stridorous or coarse sound that has a seal bark cough associated with it. These patients do respond well to humidified oxygen and ultimately will need infectious treatment to further improve these conditions. Epiglottitis is a bacterial infection causing inflammation of the epiglottis specifically. Children are more prone to this disease, but with the transition of childhood vaccinations and some folks and some populations choosing not to become vaccinated, we are seeing an increase in occurrence of epiglottitis in the adult patient. Presentation for epiglottitis is hallmarked by the tripoding and drooling position. So the patient would be leaning forward, typically bracing on their knees, and oftentimes secretions or drool is found coming out of their mouth. Treatment hallmarks for this specific patient: make sure that you position them in a position of comfort, provide blow by O2 or passive oxygenation, and try not to stimulate the epiglottal tissues. This is really important for advanced providers out there, that if you need to engage in airway management or you're looking at advanced airway techniques, stimulation of the epiglottis and the epiglottitis patient can cause excessive swelling and ultimately result in a complete occlusion of the airway. So you want to keep this patient calm, keep this patient comfortable, reduce exertion. If the patient is adequately maintaining their airway by allowing the secretions out of their mouth, please don't stick anything in their mouth to try and suction that out. You want to keep interventions to a minimum with this patient and provide humidified oxygen via blow-by method to allow some additional oxygenation to occur. Pertussis is an airborne bacterial infection that mostly affects children younger than 6 years of age. Again, we've seen a resurgence of some of these diseases with sort of the social cultural implications of vaccinations. So pertussis or whooping cough has come back in prevalence. just to be aware of situationally in EMS. Patients often will present feverish and exhibit a whoop sound on inspiration after a coughing attack, which is where it gets its common name, whooping cough. There is a risk for um, droplet contamination, so make sure that you're wearing the appropriate PPE and watch for dehydration in these patients, as oftentimes, as with any infectious process, the increased metabolic rate and fever that are associated with infectious diseases can cause a reduction in fluid intake and an excessive use of fluids. These patients may often be dehydrated.